All right, let's dive right in. Today, we're going deep on Lyme borreliosis. And this is so much more than just a simple tick bite. It's a really complex, multisystemic disease that, frankly, continues to be a huge challenge for both clinicians and researchers. So here's our roadmap. We're going to start with the pathogen itself, walk through how we diagnose and treat it, and then tackle the tough stuff, the long-term complications, and what this all means for patient care down the road. Okay, first up, the fundamentals. We have to understand the disease itself and this really intricate, dance between the invading spirochete and our own bodies. Now, this right here, this is the single most important idea to grasp about Lyme. It completely reframes the problem. Think about it. The real damage isn't from the bacteria itself. It's collateral damage. It's friendly fire from our own immune system going into overdrive. And this is why. The spirochete that causes Lyme. It doesn't actually produce any toxins. Nothing. The pathology, the actual damage we see in patients, is a direct result of our own body's massive inflammatory response to this invader. So what does this look like over time if it goes untreated? Well, it tends to follow a classic path. It usually starts locally with that iconic bullseye rash. But from there, it can spread, maybe causing heart issues. And then, months or even years later, it can morph into really severe late-stage disease that hits the joints, the skin, and even the brain.
And just to make it even more complicated, it's not all one bug. Especially in Europe, the specific type of Borrelia you get can actually predict what kind of symptoms you'll have. Borrelia fcelli tends to go for the skin, while Borrelia guerini often leads to neurological problems. For a clinician, that's a huge diagnostic clue.
Okay, so you suspect Lyme. Now what? How do we actually take that clinical hunch and turn it into a solid, confirmed diagnosis? This is where the lab becomes your best friend.
It's really a multi-step investigation. First, you've got your clinical clues. Boots on the ground detective work, looking for signs like that rash. Step 2, you bring in the blood work, looking for the antibody response. And then, in some cases, you can go for molecular evidence, using PCR to hunt for the bacteria's actual DNA. But here's the catch with those antibody tests. For a specific sign, like Borrelia lymphocytoma, we only detect antibodies about 83% of the time. Now, that sounds pretty good, but it also means that in nearly 1 out of 5 cases, the test could come back negative, even when the patient has it. That's a huge blind spot.
And PCR isn't a magic bullet either. Its success totally depends on where you get the sample from. But here's the real kicker, the thing that complicates everything. Those IgD antibodies can hang around in your system for years, long after the infection is gone. So a positive antibody test might just be a ghost of an infection you cleared ages ago. It makes telling past from present incredibly tricky. So, once we finally nail down a diagnosis, we pivot to treatment. The goal here is twofold: kill the bug and, just as importantly, shut down that out-of-control inflammatory response. The key takeaway here is that one size absolutely does not fit all. If you catch it super early with just the rash, a couple of weeks of oral doxycycline might be all you need. But if the disease has progressed to something like neuroborreliosis, well, that's a whole different ballgame. Now you're talking intravenous antibiotics, a much more aggressive and longer-term approach. Now, for kids, it's a similar playbook, but we do switch up the antibiotics, often using things like amoxicillin or cefuroxime. But the really fantastic news here is that when we treat children promptly and properly, the prognosis is generally excellent. They do really, really well. Of course, you know what's better than even the best treatment? Not getting sick in the first place. So let's talk about prevention. This all boils down to pretty simple common sense habits. Yes, avoid high-risk areas, use repellent, wear the right clothes. But honestly, the number one thing you can do is just be vigilant. Check yourself, check your kids, check your pets after you've been in the woods. And if you find a tick, get it off fast and get it off correctly. And this isn't just on us as individuals. On a much bigger scale, public health systems are keeping tabs on this. Data from places like the US and the Netherlands show that mandatory reporting is in place. This is absolutely critical for tracking where the disease is,
where it's spreading, and how we can better direct our public health efforts.
All right, now we have to get into what is probably the most challenging and honestly the most debated part of this whole story, the potential for serious long-term problems, even after treatment. And the list of things that can go wrong, it's just sobering. We're talking about arthritis that won't quit, even after multiple rounds of antibiotics. We're talking severe heart damage, chronic neurological issues, strokes, vision problems. This right here is a stark reminder of why we have to take this disease so seriously from day one. And this brings us right back to that diagnostic nightmare. So in a patient with late-stage Lyme arthritis, if you test their joint fluid for the bacteria's DNA, you might find it or you might not. The test sensitivity is all over the map, from less than half to nearly 90%. How can you definitively prove a persistent infection when your best test is that unreliable? It's a massive clinical problem.
Okay, let's pull all these threads together. What does this all mean for someone actually trying to manage a patient? What's the bottom line?
So picture this. A patient walks into your clinic. They've got a swollen knee, they don't remember a tick bite, never saw rush. This is where you have to remember that Lyme is a spectrum. You can't just be looking for the classic bullseye. You have to maintain a high index of suspicion. For that patient with the swollen knee, there is no single easy answer. You have to be a clinical detective. You're putting together all the pieces, the physical exam, the antibody tests, maybe a PCR from the joint fluid, and you're doing all of it knowing that none of those pieces of evidence is perfect on its own.
And at the end of the day, the single most powerful thing you can do for that patient is get them on the right antibiotic and get them on it fast. A 28-day course of doxycycline could literally be the difference between a full recovery and a lifetime of chronic, debilitating joint pain. It is our best, most potent weapon.
And this leaves us with the final and frankly the most provocative question of all. It's the elephant in the room of Lyme disease. What about the people who finish their treatment but their symptoms just persist? Is the bug still hiding somewhere? Did the infection trigger some kind of permanent autoimmune short circuit? Or is it something else entirely that we just don't understand yet? Answering that, well, that's the great unsolved mystery at the very heart of Lyme borreliosis.